Today, we are honored to have the Chief Executive Officer of Olympic Medical Center, Darryl Wolfe. Darryl has been the CEO at Olympic Medical Center since August of 2020, which means he started during COVID. Whoa. His prior experience at OMC includes his prior experience at OMC includes serving as Chief Operating Officer, Chief Financial Officer, Director of Administration, Treasurer, Operations and Business Analyst since joining OMC in 2006. He currently serves on the Washington State Hospital Association Strategic Planning Committee, Public Policy Committee, and Data Governance Committee. In the 10 years prior to joining OMC, he worked in management and financial services. Darryl graduated from Washington State University in 1994 with a Bachelor of Arts degree and from Pacific Lutheran University with a Master's in Business Administration. He lives in Port Angeles with his wife, Shelley, and two children, Billion and Jensen. He is very involved in the community, serving on the board of directors and volunteering for the Port Angeles Marathon Association and the Hurricane Ridge Winter Sports Club. His other interests include hiking, bicycling, running, skiing, and fly fishing. Please join me in welcoming Darryl.
All right, thanks, Laurel. Thanks, everybody, for having me. In fact, the last time I was here, my son actually got an award, so that's the last time I got up this early. No, I'm sorry. So I really want to hear from you all today. I'm going to, I have a few comments, and like I told these guys when I got here, and thanks, John, for the tech. I decided to ditch my presentation and just kind of I'd like to hear from you, but I do have some things that I do want to talk about in advance, and just sort of, fielding your questions. A little bit about me, and many of you I know, many of you I don't. So as Laurel said, I've lived in this community for all of my adult life, and I ended up marrying a local person who was actually born in our hospital a long time ago. I won't give her age away. She's younger than me though. And my kids were born in our hospital. So I think, sometimes people say, why did you take this job? And sometimes I ask myself that, especially in the last 3 years. But I think this is our place. And I think one thing that we are committed to as the senior leadership team and our board is remaining locally owned and operated. And that is kind of job one for us. And to do that is very difficult, and we have to make a lot of tough choices to make that happen. But that's kind of why I think I threw my name in the ring 3 years ago when Eric Lewis, my predecessor, decided to leave. And mentally, I feel like I've been the CEO since January of 2020. So the whole pandemic, because I'll never forget I remember the place we were, the exact moment. And he said, Darryl, as soon as we stepped off the campus, he says, I've made a decision to make a change in my life. And I said, oh, I'll tell you exactly what I said. But there was an explanation, and I said, that wasn't the deal, Lewis. That was not the deal. So anyway, he went on to do other things, and he served. He was a great boss, a great mentor, and actually hired him in 2006, coincidentally. So anyway, so I feel very connected to this community. I feel very connected to the hospital. I think that's part of why I'm standing here right now. It wasn't the plan. I'll just tell you that much. So 2022 was a tough year for OMC, but it was a tough one for hospitals across our state. One thing that we did as a hospital association at large is going into the 2022 state legislative session is starting to aggregate the economic or the financial results of every hospital across the state in aggregate. And in 2022, hospitals across the state in aggregate lost $2.3 billion. That's with a B. So what does that mean? Well, the difficulty is that costs have risen significantly, and I know the math, you have this much revenue and this much expense, and but it's not that simple. And I can just tell you from OMC's perspective, we had about a 6% 6.6% operating loss in 2022. That's there's only been a few times in my tenure there we've actually lost money and not had a small margin. As a public entity, we don't strive for huge margins, but we've been able to maintain a 2 to 3% margin every year for a long time. But 2022 is tough for every hospital in the state. Aside from a small handful of small cost-based, cost-reimbursed hospitals, every hospital lost money in the state. So do I feel better about our performance? Not really, but I know we're not alone. And so that could be a little tiny bit of comfort. So at OMC, we, like I said, we had an operating loss of almost 7%. But there's a lot of reasons for that. In 2022, we had a lot of one-time hits. You may remember something called the Omicron surge in the beginning of 2022, where we stood up a clinic. We had a drive-through testing center. Some of that was reimbursed, but much of it wasn't. We were spending $600,000 to $700,000 per month to do all that testing. We didn't have the in-house capacity to do that much volume, so we were sending a lot of it out, and that was just sort of what had to be done. We also, in the first 6 months of 2022, on numerous occasions, had to restrict our capacity because of staffing constraints due to COVID and other things, where we weren't doing elective procedures that might have touched some of you. I'm sorry, we just didn't have a choice, because I think what's elective medically isn't always elective to you personally. If I need a new hip, I want it tomorrow. But so anyway, so we had some revenue shortages in the first half of the year. We've had the very unfortunate and ongoing challenges around a provider who was contracted that we worked with. That's been a huge loss for us. And then we've had a turnover in our emergency department that's been well publicized. And so all those things together, that doesn't take into account all of the increases that we've had in our wages. What we've seen across the state, and many of you have probably heard about, is there's the workforce shortage in healthcare. It's not just in healthcare; it's in many sectors of our economy. But in healthcare, it's acute. We have as many as 75 contract staff people at any given time at OMC in the last several months. That's everything from RNs to lab techs to folks in our imaging department, to respiratory therapists, to physical therapists, to maintain the services that to stay kind of level. Those generally are 2 to 3 times the cost of an employee. The challenge is there's, as hard as we're working and recruiting and we're getting very creative, trust me, there's just not enough of a workforce out there for the needs of healthcare across our state and probably across the nation, but I can't speak to that as well. Our costs for labor used to be about 62% of our revenue. It's now about almost 73% of our revenue. And that's to achieve just revenues that we've had historically. So you have this very difficult equation. In 2023 going forward, we do have some bright spots. This isn't all bad news. Trust me, it'll get better. Some of the things that happened in 2022 will not be repeated. At least I pray we don't have an Omicron surge like we did last year, which was impact. It's hard to explain how impactful that is on the system, but just trust me that it's very difficult to wage those things. I mean, it's hard to stand up a clinic over 3 days and all of a sudden have vaccinations and all those sorts of things. And we had to take staff from other services to staff that. All those things are very disruptive. 2023, the only real the headwinds that we're going to have in 2023 are around our contract labor. Most of those other things I mentioned, we expect to not reach. So we spent a lot of time in this beginning of this year with our state legislators and working with them through our legislative session, which still is ongoing. It's the long one, but we're pretty much wrapped up. The big focus is for us, and I want to introduce Bobby and Heather from our marketing team. They're here to kind of keep an eye on me and make sure I don't get outside the guardrails they've given me. But also, Bobby's kind of my right arm in a lot of our advocacy work. But our three main focuses going into the state legislative session in 2023 were to make sure that the nurse staffing bill, as it was presented last year, which introduced a series of very strict ratios on how we can manage care in the hospital. We wanted to combat that and make that a more user-friendly and nurse-centric law, I guess you would say. Medicaid reimbursement is huge for us. About almost 20% of our revenue comes from the Medicaid program, and historically it's paid far less than costs, usually around 67-68%, depending on what part of the hospital or what part of the system you're seeking care. And lastly is just the difficult to discharge patients. At any given time, OMC has between up to 12 or 15 patients that are there with for no real medical reason, but there's really no good decision, no good place to send them. And that's been exacerbated in the last couple of years by limitations across the system, whether it's in skilled nursing care or skilled nursing homes, memory care, assisted living, et cetera. All of those agencies, like the hospitals, they're maxed out. They have the same workforce challenges we do. We're often all competing for the same limited resource of RNs, CNAs, et cetera. So they get stuck in the system. And this is at the same time as we've had unprecedented volumes in our emergency rooms across the state. So it's created a very difficult situation. So with our state legislators, trying to find ways, how do we move these people through the system more quickly? We are very, so whether it's behavioral health is another huge factor. The hospital is a safe place for these people, but that's not really what we're here to do necessarily. But they need a place to go, and when they present to us, they're our patient, and we treat them, the best that we can. But we're not a psych hospital, we're not a memory care facility, and we're not a skilled nursing home. We can provide a lot of services, but it's also very, very expensive. And so on. So those are the three big things that we really wanted to address with the state legislators. Again, staffing, Medicaid, and this difficult to discharge challenge. Which again, we're not alone in that. The other again, highly publicized discussions, if you want to call them that, are around our emergency department. And I'm not going to tell you that we've fixed all that, but I can tell you that. We're not alone, and we're trying to be as innovative as we can. We've set up what we call a rapid medical exam program, where as soon as you present to the ER, you're engaged more quickly by a provider. Your labs are started, your X-rays, if you need them, are started, et cetera, so that as you move through the process, the goal is to move you through faster. Unfortunately, that's also coming, despite our best efforts, all those situations I talked about 3 minutes ago impact the ED, because if you can't move them to the acute care, they sit in the ED, that backs things up. So I would just tell you that there's a lot of people working very, very, very hard on that, and that's a constant discussion every single day at OMC on how do we have the throughput through the ED, or improve the throughput through the ED. It's been very difficult, because also what's happening here is happening in the I-5 corridor, probably even more severely. Harborview, for example, at any given time has had up to 120 people sort of lined up trying to get into their ED, and that's our regional level 1 trauma center that we all rely on, whether you're at OMC or you're in Moses Lake or you're in Tacoma General. We're all trying to get people in there because that's our level 1 trauma. So it's not the best picture. I wish it was a little rosier, but I'll just let you know that we have highly engaged state legislators. If you know Mike Chapman or Steve Theringer or Senator Campbell Vanderweg or Derek Kilmer or Ray Cantwell or Patty Murray, they are huge supporters of us in this community. So thank them because they do work hard for us at those respective levels. Here's the good news. There's still a lot of good things happening at OMC. I think it's important to note that about 1,200 people hit our system every day. And that's from all of our imaging areas. We have imaging at the North Olympic Healthcare Network in the lab. We have it at Jamestown. So we're seeing a lot of people all the We did have about 26,000 visits in our ER. So despite how slow it is, it's very busy and there's a lot of care taking place there. In our clinics, we saw had over 170,000 visits last year. We still delivered 350 babies, which is actually down. I'm still trying to figure that one out. Our home health agency, which is award-winning and serves our whole beyond Clallam County, even in the west side of Jefferson County. Our home health agency goes to Nia Bay, La Push, way out to the Clearwater for a couple of people, and then all the way to the Jefferson County line. So they're serving everyone. And they did 47,000 home visits last year. So that's a pretty amazing thing. You know, and again, we provided over $5 million in uncompensated care to the community. So, you know, and that's what we're here to do. And we'll continue to do that. And as I mentioned, despite the challenges in our workforce, we still provided, you know, about $150,000 in benefits for our employees. Through the pandemic, we never laid anybody off. We never cut anyone's salary because we knew that when this all shook out, we would need every single one of those people. In fact, we need more. If you have any friends that are MAs or RNs, have them call me or one of those guys. And we still have 1,600 employees. You know, we didn't through the pandemic, we're still able to successfully recruit in many areas despite the challenges. We recruited, I think, 12 new providers last year. I interview every single provider that comes through for interviews, and I think I interviewed 5 providers last week. Everything from urology to sleep medicine to primary care. So a lot of activity going on all the time. And we've decided that as a non-cost-based entity, the way we're going to win is to sell ourselves. This community, you guys, this patient population, these people, that's how we're going to get out of this. I will not ever be able to outspend the big, Kitsap St. Michael's Hospital. That's never going to happen here. But I think we have a lot to offer, and I think for the right folks, this is the right place. But if all you want is the highest dollar and the best salary, we're probably not going to be your best bet. But we are fair. We want to pay competitively, and we do that whether you're a physician or you work in IT or an accountant, whatever that might be. That's our mission, and that's. But I think we have a lot to offer. Dr. Mark Fisher, who some of you may know, retired a few days ago, and I spent some time talking to Dr. Fisher, and he told me that when he started working out here, he didn't know what his salary was because he didn't care. This is just where he wanted to be, and I think those people are still out there. I mean, that's why we're all here, right? I did, again, like I said at the beginning, my grand plan was not to be the administrator of Olympic Medical Center, but I knew I wanted to live here. And I think there's a lot of folks out there like that in the healthcare setting. And this is a good place to be. And I think culturally, I think we're a good place to work. And I mean, that's why I'm still here. So that's my brief intro. That's basically what I was going to have on a bunch of slides. But I really want to hear from you all. So I will pause, but I'm happy to answer questions about anything that's on your mind. And I'll promise I'll do my best to stay in the guardrails, you guys. So I would ask, what do you want to know? Laurel, and then Tom, and then Jim.
I'd like you to talk about OMC's relationship with Winslow College. Dr. Ames has recently noticed that for the first time the enrollment in some of the medical programs is down.
Yep.
And I was wondering, obviously that's going to affect their hiring plans going forward. Can you talk a little bit about that and the relationship you have with Winslow College and the other major entities in our county? Because it seems to me like you're all working together really well.
Trying, yeah. And to specifically to the college, I'll touch on it in a second. But one thing that I do want, I think we should all be proud of is through the pandemic, no one has enough resources, right? And so what I think, whether you work with the Jamestown Clallam Tribe, North Lubbock Healthcare Network, the public health office or the county public health officer, Dr. Allison Berry, we all really pulled together really well. And as I looked at other areas across the state, it was fascinating to me how many people said, I don't even know my public health officer. And I said, well, you should know them because they're awesome and they can help you. So I think we learned really how to pull together, and, there's plenty of patients. We're doing our best to serve, all of us are doing our best to serve everyone, but there's still more out there. So we're not competing necessarily. Jamestown has its own sort of revenue stream through the Indian Health Services or the tribal health services. No one's at FQHC. They have a completely different funding source than OMC. So we're in this very unique situation where we're all doing our best and working together to make that happen. And we're not fighting. I think that's important. But part of that was through the pandemic and just a long tradition, I think, of that prior to me. And it's just, trying to work together, knowing that we all kind of have the same goals. Specific to the college, we've had a long tradition of working well with the college and helping them grow their programs. I think what some of the barriers that we hear about are just the, childcare. It's hard to go back to school when you're a single parent. It's not impossible. Housing is very difficult for folks. And so what we're actually looking at right now and talking with some partners about is, how do we set up scholarship programs that maybe can alleviate some of that burden so that people can maybe get into those slots a little bit better? Because you're right, the enrollment is down, and given the demand, it doesn't make sense to me because these are good jobs. Starting salaries for RNs, I think, is well in excess of $30 an hour right out of the chute. So it's, and I've heard even higher in some settings. We're unionized, so that's a little bit more fixed. But in any case, so no, we're closely with the college, and that will continue. In fact, I talked to Dr. Ames today about some of the comments made on a EDC call on Wednesday morning. So we're in close contact, and we'll continue to do all we can. Our chief nursing officer, Vicki Swanson, is also very engaged with them in their nursing program more specifically, just to try to look for innovative ways to make sure that those slots are filled. Because I think in the last class, they graduated, I may have these numbers not exactly right, but around 30 patients, 30 RNs, and I think we picked up about 20 of them. So that's really important for us. So to your point, so we'll continue to work on that. And I know that our marketing team and our recruiters are looking at other colleges. How do we get our name out there? Because again, I think we have a lot to offer here, and I think that's how we're going to win this. But I think we have to get out there more. So we're looking at other strategies to pick up and our retention. Looking at retention, let's keep the staff we got. So, but anyway, yeah, college is a huge player, and I think overall, again, if there's a silver lining to the pandemic, it's that we all learned to work together pretty well and realize that we're much stronger together than not. Yes.
You touched on it a little bit. A few weeks ago, we heard from Dr. Maxwell with the North Lubbock Healthcare Network, and I'm curious to what, if there's any specifics about areas in which you can cooperate, collaborate, but also if there's specific things that you compete for. Are there specialized services that maybe you offer that you hope you can have a lock on that where somebody else doesn't have to do it?
We work. I meet with Dr. Maxwell on a monthly basis to talk about these things. But no, I think the only thing that we compete on is workforce, frankly, and we kind of joke about it. We know about it, and because if medical assistants, if you're a medical assistant, you could work for Dr. Maxwell, you could work out for Paul at Jamestown, you could work for us. So we compete on workforce, definitely, and that's interesting. But I think we each have a different culture, and so each one pulls from a different place. But as far as services go, I think Dr. Maxwell and the FQHC model is really focused on primary care, behavioral health, dental. We don't do dental. Behavioral health, I think if we all did a lot more behavioral health, there still wouldn't be enough. So I don't really worry about that too much. And I think when you start looking at the specialties, surgery and those things, you really need the infrastructure of a hospital to make that work. So I think they want to be good at primary care and dental and those things, and I think we want to be good at, so I don't think we really compete necessarily, except honestly, we're forced because we're all competing for the same crew. So does that kind of answer your question?
Yes, thank you.
Yeah. I think actually Dr. Maxwell was, when I interviewed for this job, he was on one of the panels, and that was one of his main questions. He says, when push comes to shove, we need you, OMC needs to, we got to have the OR, you got to have the inpatient units, you got to have and the ICU, you got to deliver babies, so I think we all have sort of our piece of the system. And the only place we really have overlap is primary care, and there's not enough anyway. So it kind of works itself out at this point. And again, we work pretty well together. His program, the known program recruits a primary care provider who wants to do more full spectrum medicine. They may want to do colonoscopies, they may want to do deliveries of babies. So there's a little overlap there, but again, there's not enough, there's plenty of demand. So we have a supply problem, I think. So good question though. Chip.
Darryl, you and I have talked about this a little bit before, so the people in the room can be aware, and maybe you don't want them to be, but as you started out your discussion, you talked about the cost-based hospital, Fort Townsend, Jefferson County, closest to us. They're making a small margin. They're not losing money for the most part. And because the reimbursement is different, especially in Medicare, Medicaid, they get whatever they pay. They can pay more for staff than you can. All these things happen, and as I rerun all these things through in my mind after our last discussion, it seems to me that it's inevitable, unless laws change on a nationwide basis. And how hard are we been working on that? It's not happening any very quickly. It seems inevitable to me that we need to become a cost-based hospital, which means reducing to 25 inpatient beds, as I understand it, and a few other things. So it seems to me that we could take our rooms, make them all single private rooms, right? Which would then, so we could only have 25 in there at a time. And it would that would also reduce the needs for staff a little. And perhaps another revenue stream, you could rent out the rest of the rooms to a skilled nursing facility, a wing. It seems there's a lot of things that could be done if we were to say, something, the model just doesn't work to have 75 beds in this day and age and in the foreseeable future.
Those are all good points. I think that the rub is, we had 55 people in there yesterday. So what you're exactly right. And we as part of a study we did many years ago where we looked at going to 49 beds, and there's some advantages to that in the outpatient setting. There's just, if anything, we can't take care of people with what we got. So the thought of shrinking to that magnitude, there may be ways we can temper some of our services, but I think the inpatient units, until we can, because I think to your point, Jim, if we can figure out how to create some better mechanisms to get these people through the system, whether it's skilled nursing and some of these other settings, that's a huge thing economically. So I think we'll continue so we may get there, but we're not ready yet. I think, what OMC has done for a long time is pretty fiscally conservative. We've always maintained a low debt position. We've always maintained good reserves. So we can weather the storm for a while, not forever. So I think if there's going to be shrinking, it's going to be not cutting of services, but maybe there's areas we need to look at doing a little bit less. But I don't know that it's on the inpatient side. I think that, unfortunately, just the acuity, that would be a tough one to do. And I think because you're right, there are strategies where, this beds, one of your count bed and this one's not, this one's observation. You know, so there's games that can be played there. Not games, but the way the regulations work, you can actually have more than 25 beds, like your obstetrics or postpartum beds don't count, that kind of thing. But I still look at our average daily census of 45, and I think that problem that we're talking about with the ED and that backlog would get worse. Because then where are they going to go? I can't send them to Swedish right now; they're full. I can't send them to multicare; they're full. I can't send them to anywhere. Yeah, so that's the hard part about reducing capacity is I think. Okay, yeah, I think it's if the state had more beds, we could transfer more easily. That may be more possible, maybe, and that's just become harder and harder and harder. We're doing, there's just nowhere to send these people. So I don't know where they would go.
We would just be pushing the bottleneck, because if you think about what happened to our ambulance system, it would just be a beaten path.
Right.
To Seattle, that's still cost. There's still a lot of cost that the communities have to fight.
Yeah, I think,
They're just pushing it.
well, and the other thing, there is some good news that I also, that it's on the horizon is, there are some, we did, again, thank Derek Kilmer, the site neutral case, the lawsuit and all that we fought, and many of you helped support us in that in 2018, that did get rolled back. I mean, so that's $1.5 million, and that doesn't solve all the problems, but that's a little piece. There's a new program that's going to come out through the Medicaid program that's going to be probably about a $5 million improvement to our bottom line. It's called the Safety Net Assessment Program. I won't bore you with math, but that will help us. So there's things happening, and I think, again, there's so much demand out there. If we can figure out ways to get people into the system and through the system, and reduce the bottlenecks, I think there's still a lot of opportunity to explore before we start thinking about shrinking. Because once you shrink, I don't know how you'd ever get back to 75 when things change. And I think most of these things are cyclical. And maybe it's not tomorrow, but maybe it's in 5 years, maybe it's in 10 years. And I think, the fact that so many hospitals in the state of Washington are on the verge of closing, I think we have the attention of the state legislature to start really taking some of this stuff seriously. Not that they didn't before, but more seriously maybe than in the past, addressing behavioral health challenges and substance abuse challenges. And so I think we have a lot of things we can do before we shrink to that level. So, but no, you're right. I'd love to be cost-based. We'd really be winning. Oh, sorry.
One last question, Darryl. We used to meet as a club in the cafeteria. We appreciate
Oh,
John,
brother.
doing a
Okay.
great job.
Yeah.
When do you think we'll be able to start meeting there again?
Soon.
Soon, okay.
I mean,
last year. Okay,
But
so-
here's this is just to that point. What's interesting is, so we have people, my whole staff right now. If you walk to administration suite, everyone's wearing masks. Everyone's sick.
Right.
So we've reduced masking, which is fine, but now we have more people out.
Right.
So this is, even though the rest, I mean, I don't want to. I don't go the wrong way, but healthcare is still very much in a pandemic. Very much in a pandemic. And the biggest challenges that we've had as organizations have been with our staff getting sick. It's not necessarily that we're spreading it to patients, whether we're getting it. It's our staff. We have 1,700 people relying on them every day to come in and do their jobs. And when they get COVID, they can't come. There's no remote option. I worked remote 3 days in the last 3 years, and that was because I had, right? So we're very cautious.
Sure.
About opening everything back up.
I get that.
Yeah. No, that's okay. No, so Kathy warned me this question would come up.
Yeah, well, that's.
We trust me, we want to get back to normal as much or more than anybody. So stay tuned on that one.
Well, Darryl, thanks for coming. Very much appreciated.
Yeah, no, thank you. And if